Well, good morning, everybody. Today we're discussing in our hand conference elbow instability. One of the things with elbow instability, it's definitely a spectrum of injury with regards to how it presents. There's multiple pathologic conditions involved. It's a complex anatomy, the elbow in itself, and it's an unforgiving biological environment. So once it's dislocated, disrupted, there's subsequent things that happen, stiffness, limited motion, post-traumatic arthritis that can involve after these injuries. One of the things for us to understand about elbow instability in 2022 is that deficiencies of the coronary or the radial head or both, they must be treated. If there's deficiency in any of these parts of the elbow joint, the likelihood of residual elbow instability is significant. And one of the things is that the most important postoperative rehab concern is to avoid various gravitational stresses to the elbow. And that's with using the elbow away from the body, grabbing an object, extending out, and that produces significant amount of strain on the lateral complex and shear on the medial side of the elbow. And this is how it tends to fail. And if we tend to do this early after our repairs, that's when we have the gapping and the opening and the stretching of the lateral collateral ligament complex. One of the things of the anatomy is pretty precise and it's pretty constricted, but it's pretty fascinating in the sense how it's built. So the three bones, if you were to look at them, they meet at the elbow joint. The distal humerus is in the bone and the forms, both the ulna and the radius, and the articulating ends of the upper part of the ulna, which we know is the coronoid, and the olecranon. Basically, what they are is like a retaining wall. They basically behave in preventing that lower part of the humerus, the distal part of the humerus, to jump over. And when any of these retaining walls are disrupted, or even basically what retains it, or the holds the ground, the ligaments, that's when we have a problem. So one of the things that we discuss is the primary stabilizers of the elbow. One second is how we'll discuss the primary stabilizers, the secondary stabilizers, and the dynamic stabilizers. I'll touch on the primary and secondary stabilizers. The dynamic stabilizers, what we refer to those are the forearm flexors and the extensors. So the primary stabilizers, when we state that what is the primary stabilizer, the capsuloligamenous components and the osseous and articular components. And if you look, the lateral collateral ligament complex originates from the lateral epicondyle anterior to the common extensor origin. It has two portions. It has the radial portion and the ulnar portion. The radial portion also stabilizes the radial head. It attaches to the radial collateral ligament, or basically to the annular ligament, and it functions as a varus restraint and stabilizes that radial head on that lateral side with the annular ligament. The ulnar component, it basically inserts into the supinator crest, and what that prevents is a primary restraint to basically the forearm kind of shearing off to the posterolateral aspect. And when you disrupt this portions of both portions, that's when you have the instability of the radial head as well as the ulna dissociating from the distal humerus. If you were to look at the medial side, we tend to hear more about the medial side, especially with sports injuries, with throwing athletes. You have the medial collateral ligament complex, which is the anterior bundle, which is the anterior band. It tends to be the one that we tend to reconstruct in a sense when we're doing instability on the medial side of the elbow. There's some talk on addressing the transverse of the posterior band of the MCL, especially when you have significant sag. And usually this is not that you repair that ligament, but it's that tissue that peels off the proximal ulna and that you tend to reattach there when you're doing your repairs. Again, the anterior bundle is the primary restraint to valgus stress. And when excentrically basically stress with respect to the ulnar humeral joint, that's when it becomes tight. For the osseous component, we know that the ulnar humeral joint, the trochlear joint in itself, the trochlea, articulates with the distal humerus. It's about 300 degrees of cartilage covered area. And it's the most confined articulations in humans, and it provides significant bone stability. If you look at our joint axis of rotation in the elbow, it runs from the capital to the anterior inferior aspect of the medial epicondyle. This is important to know, especially if we're doing guide pins, especially center axis pins for hinge external fixators. Remember that the distal articular, the humeral articular surface basically lies in 5 degrees of internal rotation, 6 to 8 of valgus inclination, and an anterior tilt of 40 degrees. That's what you have if you consider the distal ulna as a retaining wall. It's tilt anteriorly. That way, when it flexes, that coronoid has more room in order to kind of fit into the distal humerus with that anterior tilt. If you continue with the anterior tilt of distal humerus that we just mentioned, it's the increased prominence of the coronoid process resists that posterior subluxation throughout the range of motion, and the increased flexion ensures the clearance of the coronoid, especially that anterior tilt. The coronoid and the olecranon fossa, they interlock in each respective position and provide stability in the extremes of ulnar-humeral motion. Basically, at the extremes of extension and flexion, both the coronoid and the olecranon provide that stability. So these are our primary restraints. In addition to with the part of the primary restraints is the trochlea. Again, remember that the trochlea in itself interdigitates with the ridge of the trochlear notch for added stability, and that in itself contributes to varus valgus and rotational stability. And we know that varus stress resistance is 55% in full extension and 75% in 90 degrees of flexion. That's why if there's somewhat residual instability, we tend to flex more of the elbow to use that to our benefit when that trochlea is intact with the semilunar notch of the proximal ulna. That's why we tend to put them in flexion. Just a little bit about the secondary stabilizers, because we will kind of touch that, especially for terrible triad injuries. It's the radial head and the elbow joint capsule. The radial head and neck, remember, they lie in a valgus angle position of 15 degrees with regards to the radial shaft. The radial head contributes to the force transmission across the elbow throughout the range of motion. When the medial collateral becomes insufficient, then it becomes more of a primary stabilizer to valgus stress. The radial head has maximum contact stresses with the elbow extended and the forearm pronated, and the radial head transmits as much as 60% of the load across the radiocapitular joint. The capsule, we always forget about this, but the capsule, when it's disrupted in traumatic events, provides as much of a third to 40% of resistance to varus valgus in full extension. And its contribution does decrease with flexion. That's why sometimes, even with a type 1 coronoid fracture, and we still put sutures around the capsule, it's because at least that 40% of resistance to varus valgus in full extension, it will be provided. And if you have a total triad you repair and it's somewhat loose, sometimes that's why going back and putting those sutures in itself do help, because they help with the varus valgus instability and the gapping that you tend to see in x-rays. For elbow dislocations, what we're going to do, we're going to break them into simple and complex. Classification of elbow instability, with simple means no associated fractures. And this is a type of dislocation we tend to see in young patients, less than 30 years old. We tend to also, and the complex ones, the ones associated with fractures, we tend to see them in older individuals. Definitely there's variances in it, but that's usually the thinking. And then we discuss how they present, if it's acute, chronic, recurrent. And again, remember, these categories are not mutually exclusive. For acute instability, it can be either complete, incomplete, or angular varus valgus. They can be chronic, non-reduced. And this is just very important for when our resident staff or fellows see these patients, just they communicate with the attendings, just to kind of report in a sense of this is an acute, chronic, angulated, and just a positioning. And the recurrent, it can be dislocation, subluxation, and we'll talk a little bit about that into varus valgus. And then we have two different forms of instability, and I'll touch base on that. It's posterolateral rotatory instability and posteromedial rotatory instability. If you look at the acute dislocation, median age, as stated, is in the younger male, active males, and 30 years old. Simple is more common than complex. And again, we describe these simple dislocations with regards to the direction of injury. So 90% of them are posterolateral or posterior simple. Anterior lateral and even medial dislocations are also reported, but the most common that we tend to see are posterolateral and posterior, and that's with regards to the distal segment of the part of the arm or the forearm, elbow that's dislocated, how we describe them. Complex dislocation is once they have a fracture. That's when it's considered a complex dislocation, and it includes fractures of the radial head, the coronoid, the olecranon, or the distal humerus. And these tend to, the more injury you have, it tends to increase the risk of post-traumatic arthritis and also the possibility of chronic or recurrent instability. If we talk a little bit about the dislocations, the mechanism of injury, there's two portions of it that were initially described in the early 1990s by Dr. O'Driscoll. But basically, he based this on what is called the Heim concept and Horry's cycles, and I'll mention that here in a second. But usually for posterolateral posterior dislocation, it tends to be a mechanism falling with the outstretched hand, meaning that your arm is externally rotated and hyperstimulated when it hits the floor. Then you have a valgus force into the elbow, and that hand contact with the ground, as the elbow flexes, the body rotates internally on the elbow, and that valgus moment kind of produces that posterolateral dislocation. And this is a progression of injury. And this is what we call the Horry concept, or the circle concept, which it starts from medial to lateral. So it starts from lateral side, posterolateral rotatory subluxation, and then progressing to the medial side. And that's what actually in the lower pictures, you can see that it starts from being gapping posterolaterally to perching and then complete dislocation. And this is a stepwise approach as it was done in biomechanical studies. And again, this type of patterns tends to be with the posterolateral, or what we call the valgus posterolateral instability. And again, it continues in stages, and it goes from medial to lateral. And then the last stages is when you get to that 3B, when you disrupt that anterior band of the medial collateral. The articular congruent dynamic stabilizers are the only ones that maintain that reduction. And when all that is lost, that's when you have an acute dislocation. So with acute dislocations, most of the ligaments are disrupted. In some portions may not, and you may have a portion of the MCL still attached, but then basically your dynamic stabilizers are what holds the reduction. And again, this is a pattern of thinking from lateral to medial, especially for the type of injury, valgus posterolateral instability. And aside from the Horry concept, it's the Heim's pattern of injury, which I'll mention a little bit, and that is referring to a column type approach. This is not used as much, but it's good to understand, because when we see fractures, if you were to think of it as a column approach like we do for the distal radius, lateral column, intermediate column, then the more columns involved, the more instability you tend to have. And that creates a specific injury. All those columns create a ring, and the more disruptions of the ring that you have, the more instability. For example, if you have a medial epicondyle fracture, more likely you can have MCL disruption. But if you have more involvement of the larger or coronoid piece fracture, that tends to disrupt all the medial column. And this is what is referred as Heim's pattern of injury. Again, as shown here, you divide them into lateral column, anterior column, medial column, and posterior column. And what's testable here is the more columns involved, the more likelihood you're going to have instability. So again, anything that with regards to ligament, fracture patterns, disruptions of the bony elements, all those things we're going to try to put back in order to create and basically to resolve that instability. Important note about radiographic assessment, good radiographic x-rays are necessary. Obviously, we want to get AP laterals oblique. One of the things, articular injuries are in about 25 to 50% of elbow dislocations. In my practice, I think a CT scan with 3D reconstruction is a must, because once you get in, is a constrained anatomy. You want to be able to see everything beforehand, and using 3D reconstruction, subtracting the distal humerus is significantly helpful, especially for addressing the coronoid, because just one subtle miss on the corner that you don't address, the instability pattern can persist, and that is detrimental to the patient. And this is, again, demonstrating the pattern of injury. This is in the type 2, where you have the perch when it goes from posterolateral, and sometimes patients will present in this position, and this is the perch subluxation, but it still hasn't completely dislocated thoroughly, but is in that pattern, in that third pattern, if we were to think of that Horry cycle from lateral to medial. And again, this leads to the simple dislocation. And what happens in some of these, and if it gets through to the posterolateral aspect, that's when it will fracture the coronoid, and usually the anterolateral portion of that radial head. And again, this is an example, and this we would describe, as a posterior, as is on the lateral view. And if you can see the distal segment on the AP view as lateral. So this is a posterolateral dislocation, simple dislocation. For the treatment and evaluation, you really have to evaluate the patient in the sense of look at the arm, look for open, and the physical exam, look for pain, soft tissue swelling, deformity of the elbow, document all that, document any open injuries, and the amount of swelling that we have. The mechanism of injury is very important also to document because it dictates our treatment plan, treatment options. And do a good neurovascular assessment. Brachial artery injuries are rare. Usually, if they do have any issues with arterial or subsequent loss of pulse after reduction, tends to come back. Assess all three major peripheral nerves. Ulnar nerve is the most one that we tend to see a lot of pathology, but assess the radial and the median. Monitor the compartments and look for ipsilateral injuries. Again, it's very important to look not only at the elbow, but look above and below. Look at shoulder injuries, which we can see in 10 to 15% of the cases, and also evaluate the forearm and the DRJ for instability. And again, in some cases, we do repeat the exam after reduction, and that's more likely. The best thing to do is get the reduction, then come back and do your exam if you're able to. For simple dislocations, what is the main treatment? Well, the main treatment is getting them reduced. And once you reduce them, you kind of, if you're able to, you assess the range of motion to kind of look for the stability, basically the position of most stability. You don't necessarily have to do it in the acute setting where you test for valgus instability or varus instability. But if you were to test for valgus instability, you pronate to kind of tighten those lateral aspect of the elbow, and then see how stable the elbow is in extension. Because once you get up to past 30 degrees of terminal extension, it's still unstable. That's just by definition, it's a surgical. Basically, what we tend to say, it's a very unstable elbow, more likely something likely to get done. Remember, evaluate the post-reduction films. You want to have your AP center on the proximal ulna. You want to have a true lateral view. You want to look for that teardrop. And you want to look at widening of the joint space. Sometimes you may have intraocular fragments and will need surgical removal. And that's when subsequently, once you have the reduction, that's when I think the CT scan does come and play a good portion of helping you and assess the severity of the injury. Reduction requires IV sedation, and severe muscle spasm and swelling do require general and regional. So if the patient's severely swollen, the compartments are not as soft, and it's going to be a difficult reduction. The patient's fairly large, tends to carry their arm in varus. Sometimes these is actually better doing the reduction under anesthesia, but by all means, you do require IV sedation and muscle relaxation in order to get these reduced. You want to correct the medial and lateral displacement. And then you put that elbow, you assess the terminal extension and put it in the forearm and the elbow flex in that position of stability. And again, you'll feel a palpable clunk, and that provides the clue that post-reduction stability. In our ER, we do have fluoroscopy, which is very helpful. But this is kind of, the process how we go about reducing these. The concentric reduction in stable joint, does provide good outcome once we get them reduced. We recommend immobilizing them at 90 in flexion and neutral for 5 to 7 days. And then what the data really shows in simple elbow dislocations is that you don't want to immobilize past 3 weeks. If you get to a point that you have significant soft tissue injury in addition with the simple dislocation, sometimes it might be not unreasonable to hold them a little longer, up to 2 weeks, and that's not going to be detrimental. And you want to obtain films on a weekly basis to make sure you maintain your reduction. If you were to look at this prolonged immobilization study, that is the one quoted, it was in 1988. And what they found was once you were from 0 to basically almost 2 weeks or so, and once it got to 2 and 4 weeks, that's when you started seeing changes. But this is what they were looking at, good and excellent outcomes. So within that 2-week period is your golden that you want to move them early. But if you have to hold them 1 more week because of the situation, it's not unreasonable. You'll still be able to work and get that motion back. But again, the prolonged mobilization after that 3-week period, that's when we start seeing changes, especially based on this study, that they started to become significantly stiff. And again, these were older patients in some set of the study, not as always as we see in young patients that tend to be a little more resilient with getting their motion back. If what we talk about is allowing that early motion, you want to avoid aggressive PT because of the possibility of creating an inflammatory response that may lead to stiffness, HO. And usually this, you have to advise patients that they do get the motion. Most of them will get it all back if they're treated appropriately, but it can take up to 6 months. And that's where you really have to have that conversation with the patient and kind of let them know the severity of the injury and what to expect. Non-surgical outcomes, if you were to say, look, if we had a dislocation and none had related residual, and you have all the ligaments disrupted, why are we treating none up? Well, they tend to heal, and this is based on these studies. And none has symptoms with residual instability. So loss of extension is more common when dislocating and as we get older. And this is one of the things that they were able to state, that you can treat these simple dislocations without surgery, because people were questioning, if you have a dislocation, you have all the ligaments disrupted, why are we not fixing them? It's based in these studies early on that we were able to know that they kind of heal down and they becomes congruent and stable. In conclusion, simple dislocation, intrinsic stability from the osseous component of the articulation provide for the capsular ligamentous healing and restoration of elbow function. And again, this is the same with regards to that study where we're losing the terminal extension, was what they tend to lose the most. For surgical repair, when do we repair these simple dislocations? The question is, I think there's a spectrum of injury, and the patients that may have, that you reduce and they have significant disruption of the flexor pronator mass or the extensor supinator mass, those I think most of the ones that we tend to basically need to do something with these simples. And how do you know that? That's with the exam, and these are the patients that you do the simple reduction and then they don't tend to hold. And we see a spectrum, either a very high energy mechanism with a simple dislocation, or the older patient in their 60s, 70s that have a significant dislocation. They don't tend to fracture their segment, but they definitely evolves their flexor, extensor, supinator masses and their dynamic stabilizers. And these are the ones that do require surgical repair, because just the bony osseous elements won't hold them, because this disruption to the soft tissues is so significant. Again, muscular flexor extensor origins act as secondary dynamic stabilizers to the elbow. In a subset that do have the simple dislocation, when this is severely disrupted, that's when you would require surgical intervention. Again, in the simple dislocation, when they had recurrent stability, was rare, it was 1 to 2%. Again, this is a spectrum of injury, and we tend to see some of these soft tissues in high energy mechanisms, in addition with the older patient population. For the surgical intervention, if we were to go and have to do the reconstruction, we tend to repair first on the lateral side. We tend to go, if you were to think of it, you go from lateral to medial, you go from deep to superficial in your process. The chordaal ligaments and extensors are found torn, usually from the humeral origin. You want to protect the ulnar nerve if you have to do any medial type of work. You can use sutures through bone or bone tunnels, and then early protected motion guided by hand OT. If you see on that bottom pictures, when I'm repairing my lateral collateral, I tend to incorporate the extensor mass, the extensor supinator mass in my repair, then bring all that together, especially if you're using anchors, that tends to help. So incorporating both. And again, be mindful of your positioning, of your suture placements. You also don't want to place them too medially, and be aware of all neurovascular structures. When do we use neutralizing devices, especially if you have instability after the repair? Basically, you address the lateral side, and then you assess your exam and fluoro, still the medial side, you address that. You still have residual instability. In my practice, then that's when I use a neutralizing device, meaning the tissues for repair may not be of good quality. I don't have a very good fixation of my coronoid. I don't have a very good fixation of the radial head. And subsequently, that's when I tend to neutralize it. The dynamic external fixators, such as the internal joint stabilizer, allows early range of motion. I don't tend to do this when you have significant coronoid involvement on the medial side, because they don't tend to do well. I've had the ones that I have failed in my practice as when they involve significant part of the medial column of the coronoid. And those I'll just use a regular external fix and basically use it as a neutralizing device and put them at 90 degrees and then go from there. So rigid external fixation should apply temporarily, meaning these neutralizing devices. The static X-fix in my practice, if there's severe soft tissue disruption, I don't tend to use IGS. And the other thing that I should have put here is the medial column involvement. And again, remember, this is a neutralizing device. It's not that we're moving them early. It's just holding everything in place. You want to have that reduced joint, and if it gets stiff, we can always address that later. And consider when do we do flexion contractures? I tend to do it about 6 months and above, and it's when it's greater than 30 to 40 degrees at terminal extension, and it's severely patient to the patient, and they're not responding to the other modalities that we provide. The long-term results about simple dislocation, the incidence of HO is less than 5%. I guess once you have more fractures, more disruption, more higher energy mechanism tends to be much higher. It's been reported HO and stiffness up to 40, 70, and 60% in some studies. The period mobilization, again, limited to under 2 weeks. Minimal loss of terminal extension, you need to tell the patients the 6-month process. Minimal stiffness if you're able, and that stiffness of terminal loss of extension is because of the anterior capsule fibrosis. Minimal pain with daily activities and residual instability. As we move from simple, we'll go into elbow dislocation, the complex portion, and I'll touch base, towards the end with the cerebral tri, which I think is applied. We don't have anything through the year that addresses cerebral tri, and I'll try to touch base on those. For complex dislocation, as we stated before, they're the ones that involve fractures. They're less frequent, more difficult to treat. And again, if you have at least one osseous structure in conjunction with elbow dislocation, there's risk of recurring instability and arthrosis. And again, the important concept to understand is that this is, so they add to each other. If you one plus the other, the more you have, the more instability likely. And fractures of the radial head and coronal process are the most commonly seen and are the ones that we need to address. Factors that influence outcome, this has been tested, and that we have to ask the patients, previous failed surgery, previous surgery in the elbow. When we get to these fairly late, it's significant on the outcome, especially after 2 weeks. Comminution of the corner and the proximal ulna. The severity of dislocation, fracture displacement, and age of the patient. Some of the older, and again, we tend to see fracture dislocations in the older patient group. And this is something that has been shown to be correlated when you have these type of injuries. When associated injuries in the soft tissues must be addressed, you need to reduce that dislocation, manage the fracture, repair the ligaments, and then look if you need to do the neutralizing device. The way we break them down is addressing your radial head, your coronary fractures, your ligament injuries. You may have a variant of what we call Monteja variant or transolecron. I'll mention a little bit about that just because they're associated with instability. But these are the categories that we're going to be talking about. One thing about the coronary fracture, we tend to see them in about 2 to 18% of dislocations. And usually most of these, in specifically in cerebral triads, they tend to involve the coronary tip. They tend, the coronary tip that's fractured in cerebral triads, about 35% of its height, usually about 7 millimeters. The larger the fracture segment of the corner, the more likely it's going to compromise instability. The anteromedial facet or anteromedial fracture, it's a different mechanism. It tends to be seen more in varus posteromedial instability. And then you have the other pattern, which is the basal fracture. And what happens with the basal fracture is that you lose that continuity of the brachialis in that insertion of the anterior band of the MCO. The initial classification shown on top was the Reagan-Mori, but now subsequently we've modified to the O'Driscoll classification, which breaks it into tip fragments, anteromedial facet fragments, and basal fragments. What we see in cerebral triad injury in varus posterolateral tend to be tip fragments, and they tend to do not extend medially. They don't pass the sublime tubercle, and don't always have to be fixed. In a sense, that's a caveat, because when we don't fix those tip fractures in cerebral triad, you have to make sure that you have a solid fixation on the radial head or a radial head replacement. You have a solid lateral collateral ligament complex repair, because then that stress on the lateral side is going to increase. And if you have a tenuous or even an avulsion, then you're losing that part of instability. So you have to make sure that when you treat them non-op, the type 1s, that you have a great lateral reconstruction. Anteromedial facets we tend to see with anteromedial varus instability. Again, they're either classified TIM at the tip, at the rim, and they are additive to each other and extending to the sublime tubercle. And then basal fragments, those involve the height. And that's where some of the newer things are based on these fractured fragments on the basal fragment. And again, remember the soft tissue attachments to the ulnar coronoid process, the capsule just attaches past the tip. At the base, remember, of the coronoid resists anterior translation, and the base of the coronoid in itself is the insertion of the collateral and the brachialis. Coronoids, we do try to address them, the tip fractures. If there's residual instability and it's a tip and we examine, that's when doing the lasso repair, and you want to stitch through that small fragment. And why? Because that anterior capsule does survive about 30% to varus valgus instability. Large coronoid fragments we tend to address either through lag screw and fixation, depending on, or anteromedial buttress plate. Again, depending on the type of the coronoid may dictate the type of approach that we address. The bigger the piece, the more likely we're going to, and involves into the medial side of the coronoid, we tend to go medially as compared to just laterally. And on the lateral side, we tend to do this when the radial head is fractured, or you're going to replace it. You do your work first on the coronoid and then do the radial head. If not, you won't be able to get the work done on that lateral side. If you have the radial head, you would have to completely dislocate the elbow and doing that work from the lateral side. And again, different ways of doing it, doing the coronoid tip suture lasso technique, or if you have a transolecranon shown in figure D, working through the fracture site, or doing through a medial column approach where you have to mobilize the nerve or go on top of the nerve or split the FCU. And one of the things that they've addressed recently is the basal portions of the coronoid. And they've basically described it here in Barlow and O'Driscoll in 2021, the classification of this part of transulnar fractures. And what they broke them down and were able to identify these basal coronoid fractures. They were able to break them into three. They said that the proximal transulnar fracture dislocation type 1 was the transolecranon. The basal coronoid, which is a basal sub type 3 in the Reagan-Mori classification, and the Monteja metaphyseal fractures. And what happens is that they're stating that the coronoid, medial coronoid in itself is the fragment that we need to address. So for example, in a transolecranon, usually the coronoid is separated from the olecranon, but the coronoid remains attached to the ulnar metaphysis. In a Monteja, usually the coronoid is attached to the ulnar metaphysis, and the coronoid remains attached to the olecranon. So again, with the basal piece, it's free floating. And why? And I'll show another picture here as we move forward. In the proximal transulnar type 2, it's very important to recognize when the piece on the picture on the left, when that is completely detached, then we have to reconstruct this and stabilize this fragment, because if not, you're going to have residual instability. In the other Monteja, we treat it accordingly. In the transolecranon, we basically reestablish a proximal semilunar notch. But in these basal transulnar fractures, because you'll see these, and what I've seen that has been done is that they reestablish the proximal semilunar notch and don't address that constant fragment. Think of this as the constant fragment that when we treat calcaneus fractures. The coronoid is separated from the ulna and the olecranon, and the coronoid is still attached to the ulnar metaphysis in the proximal transulnar type 1. And this is one point that that was made, and that's where this new classification is based on. So just for our resident staff, beware of this, because this is something that can be asked on the in training. So and these are the ones that when you have that free floating fragment of the coronoid, that it leads to that instability, and that's when you can have these shear type injuries as shown in the picture here, because that free fragment, there's a free fragment piece of that coronoid in the medial side that's completely off. And these are the ones that don't only have an injury pattern like varus posteromedial, but also have dissociation of the bone or shearing either in varus or valgus. And again, this is the same type of pattern. So look for these, because when you see these type of coronoid fractures, these have to be addressed, and then you build from there on. So when you start fixation, you reduce this first, and then from there build on for your fixation, instead of doing the olecranon first, because if not, you won't ever get the reduction and you won't ever get a congruent joint. So this is very important to note. And again, as we move forward, again, this is just showing the amount of subluxation that you see here on the AP, just with that coronoid piece that's off. So that's the fracture pattern that we're talking about, that type 2 basal pattern that has been recognized. Last but not least, we'll talk about terrible triad, which is one of our bread and butters here in our practice. Terrible triad is referred to as dislocation of the radial head, fracture of the coronary process in association with a dislocation. In the early 1990s, they described they were difficult to manage just because they had poor outcomes, but now we're getting better outcomes because we're kind of understanding and addressing them with rigid fixation and early range of motion. They do have risk of recurrent and chronic instability, stiffness and post-traumatic arthritis. Not always the post-traumatic arthritis is what subsequently becomes symptomatic, even though they may have it in x-rays. What happens is, as that mechanism, posterolateral, valgus posterolateral injury, as that anterior buttress of the proximal ulna and the radial head is lost, that retaining wall, the distal humerus kind of fractures that tip of the coronoid and that anterolateral piece of the radial head, and that's what leads to this terrible triad variant pattern. And again, one of the things that has been shown with the radial head fracture of the terrible triad is it's very important to treat it and address it. You have to address the coronoid injury, the ligament injury, and also understand the effect of gravity, especially in your post-op and how you stretch your injury. And also noting that importance of the radial head, and we'll kind of touch base on that. For the physical exam of this injury, again, it's just looking at the soft tissues. Very important to note the history mechanism, pronation, supination, mechanical block after reduction, because that can dictate and help with some of these that if you were to treat them non-op. And again, imaging. And I tend to recommend doing 3D and 3D subtraction because it helps me a ton with my planning of surgery. And again, interossseous membrane and wrist instability, also look for those. And with the exam and anesthesia. Don't forget the effect of gravity, and that's when you start pulling the arm away from the body, especially in our patients that are heavy set, tend to hold their arms in bears. They tend to stress or repair. So those are things that you may need a neutralizing device, such an internal joint stabilizer, and add that because of the component of gravity. And just being aware of that will protect your reconstruction. The ligament complex and the anteromedial coronoid at risk with gravitational forces. And remember, on the lateral side, it distracts. In the medial side, it fails in shear. And this is very important because of the significant amount that we don't always pay attention to this. And this is why we kind of also modify our rehab. The importance of the radial head is not expendable. It contributes significant to instability. And, one of the things is if you have a fracture of the radial head and a fracture of the coronoid, and you were not to fix the coronoid, your radial head becomes significantly more important in the sense of providing that lateral stability, the stability to the instability. So if you were to treat a tip coronoid fracture without surgery, you really need to make sure you have a stable radial head fixation and a strong lateral collateral ligament repair, because once you start moving, that's going to basically stress that radial head and that coronoid significantly because you don't have that coronoid piece. And when I try to fix or replace, well, radial head, if it's in continuity with the neck, I tend to try to fix it. If it's 4 more fragments replacement in the very young patient, that's defined as less than 30. I'll try to fix it as possible. But do I have some that I've replaced? Yes. But if possible, I'll try to do an open reduction neural fixation. And then look at your coronoid status. Replacement, if my coronoid is very tenuous, it seems unstable, since that I do the radial head and I range it from 30 to 120 and it's still gapping, then for these, though, I tend to either do my capsular repair. If I have any history of osteopenia or osteoporosis in the patient, or neck comminution, because remember, this is going to be stress after you start moving that fixation, so I'll tend to do a replacement. And this is just things that I do in my practice that I've learned over the years. And this is one of the how I would guide my treatment for those. And these are just examples of screw fixation, posterior medial plating, and radial head replacement. For radial head fixation, expose it through cokers or Kaplans. The screw fixation is what's preferred. I would recommend avoiding place if needed, because the removal of plate in order to get back pronation supination in the literature is above 95%. In some cases, I do use selective threaded wires. And again, beware of your screw length, especially into the lesser sigmoid notch, to really get good fluoroscopic views. What I do, I've memorized the length of my screws when I'm using these. and with the MedArtist tray, which is what I use. I know they're usually between 16 and 18. Once we start measuring, they say 28, 29. Well, that's disaster waiting to happen. So just kind of memorize and be aware of that, and be aware of the neck comminution. The more comminuted the neck is, the less likelihood I'm going to try to do screw fixation. For replacements, either as if you do loose fitting or you do anatomic, be mindful and know your system and know when to use it. What I would not recommend is doing a bipolar component in the acute setting, because that significantly increases your chances of residual instability. On the very young, at times you can also do an on-table reconstruction, and this will act as a spacer, and it can create a pseudoarthrosis. And sometimes most of these pseudoarthrosis in the very young are symptomatic. And if they become symptomatic, you can always replace. So that may be an option to consider. One other thing is, remember, of the coronoid in the terrible tri, it tends to be a tip, and it tends to be in that type 1. It does not tend to involve the anteromedial. And again, you can ignore suture fixation, retrograde screw, anteromedial plate if it starts becoming bigger or extending into the anteromedial side, or you can use autograft from the radial head. When to consider non-op for the coronoid? Yeah, I think the biggest thing is your exam under anesthesia. If you were to do it, do your radial head replacement and do your lateral side repair, and then do an arc of motion between 20 and 120 degrees. If you see gapping, then that's more likely that sometimes you may need that suture to the capsule. For the type 2 anteromedial coronoids, when can we treat those non-op? As we said, the importance of that fragment, because if it gets big, it leads to that instability of that basal pattern, kind of like. The requirements in some of these studies are that subtype fractures, that you have to have a concentric joint, a stable arc of motion, a minimum of 30 degrees, and that they were less than 5 millimeters. And that's where the CT becomes helpful. For the type 1 fracture, the fragment size remains small, less than 5, and that the MCL is intact. And one of the caveats to understand is that when you see a coronoid fracture and you don't see a radial head fracture, think of it as an anteromedial pattern, because that's ominous. So be aware of that, because when you have a dislocation without a radial head fracture, is an anteromedial variant until proven otherwise, and those are bad actors. And that's when you need to consider that varus posterior medial instability and really do your exam in assessing the bony components of it. The neutralizing devices, in my practice, about less than 5%, but lately in the past 4 or 5 months, I think I've put more neutralizing devices than, I don't know. I guess they come in that in spurts, but usually with body habitus of the patient is important. When you have tenuous fixation of the ligaments or the coronoid, severe soft tissue, internal degloving, delayed presentation of the patient. When patients present dislocated for more than 2 weeks, I'll put this even after I do the reconstruction, because they're going to fall back to that position. The static X-fix, I leave it in place for about 4 weeks. The IJS, I remove about 8 to 10 weeks. And that's just what, in my practice, it varies in the literature how everybody does it. This seems to work for me. Can we treat the terrible triad injury? This is something that's been questioned. Yes, you can, but you really have to follow these patients weekly. You have to have a concentric reduction. The radial head fracture is the anterolateral piece, but you have to make sure you don't have any block to motion, supination, pronation. You have to have that small type 1 and the stable arc of motion, that if you get past 30 degrees, it's not unstable. If you have any residual instability, go ahead and fix it. And again, you have to follow these weekly, but this has been shown it can be done. Post-op management, I tend to splint my terrible triads for 2 weeks. And this was also recommended in our elbow meeting that I mentioned, because you give the soft tissues a break. And the biggest thing is that when you put your splint for the terrible triad post-op, that you have to make sure you go high in the humerus, especially with patients that are big, fairly broad. They tend to hold their arms in varus. That splint has to be high in the humerus. You do address HO and stiffness prophylaxis. I do that in my practice, especially the higher the mechanism of injury, the more likely this is going to take place. And then we'll touch a little bit about overhead motion and active assisted motion. For the post-op rehab, it depends on your exam, but more likely is getting gravity eliminated range of motion, and that's what protects your elbow. You want to do early overhead supine active motion with isometrics. In addition to doing that, you want to do it actively because that fires your dynamic stabilizers, and that's what prevents the gapping on the ulnar humeral joint after surgical repair. And again, you want to have gravity protecting against that lateral collateral ligament stretch. You want to have active assisted flexion and extension in overhead, and this is the way we rehab these elbows. In a sense, you tell patients to avoid early shoulder abduction as well, and also to avoid reaching out and grabbing things because that stretches your repair, especially if they tend to hold their arm in varus. And this is one of the things that has changed over the years that we've really learned how to manage these patients afterwards. A little bit about HO prophylaxis, it varies. One of the things, I don't use radiation anymore. The data is showing, especially for Mayo in our elbow group, they showed a high infection rate. So they'll be mindful. And again, if they have two fractures, there's an increase of malunion. For stiffness, the concept is that you want to address the inflammatory component and also address the mast cell stabilizers, and that's what I tend to use. And that, in my practice, is either Metrodospac and Celebrex, and I also use ketotofen, which is a mast cell stabilizer, basically an antihistamine. And that is based on this right here in this Nuremberg study, and that is because that has also been shown to significantly contribute to your elbow stiffness. So I do combine some of those with my practice. In summary, simple elbow dislocations are more common in the younger patients than complex. Dislocations are not as common, and we tend to see them in older patients. Describing the direction of dislocation, 90% are posterolateral or posteromedial simple. The complex elbow dislocations, they involve fractures. They're less frequent, more difficult to treat. You have to address all the injuries, and these are the ones that are usually associated with poor outcomes. But in summary, the deficiency of the corner or the radial head or both, you guys need to treat this in order to avoid residual instability. And remember, the most important post-op rehab concern is to avoid that varus gravitational stress that is applied to the elbow, such as when grabbing an object away from the body. And that's all I have. I know it's a lot. Any questions?
Muchas gracias.
De nada.